Good afternoon. My name is Vladimir Maletic. I have been member of the steering committee for Psych Congress for the last decade or so. It is my great honor and privilege to introduce to you our next speaker, Professor Michael Thase. Dr. Thase is Professor of Psychiatry at Perelman School of Medicine, University of Pennsylvania, Philadelphia Veteran Affairs Medical Center in Philadelphia, Pennsylvania. Indeed, our guest really does not need introduction. If you were following developments in treatment of bipolar disorder and major depressive disorder in the last couple of decades, every major development has been associated with the name of Dr. Michael Thase. So he is an internationally known speaker, one of those rare individuals who not only is an incredible researcher, but also a very original mind and thinker and just a fascinating speaker. So I think you're in for a treat. Topic of our next presentation is Neurobiologic Insights into Major Depressive Disorder, an update on emerging therapies with novel mechanisms of action. So please help me welcome Dr. Michael Thase. Thank you.
So thanks, Vlad, for that kind introduction. It's so nice to see so many people here at this great continuing education meeting. And I think I've spoken at all but one of these over the years, and I'm always delighted to come back and see so many familiar faces. So this talk is a big challenge for me because, as probably you know, I'm not a neuroscientist. I'm a psychiatrist. I treat patients. I hang out with neuroscientists, but I've always enjoyed thinking about how our treatments work in relation to what we know about the brain and trying to understand how we can develop better treatments for our patients as we know more about brain function. So that's kind of where we're coming. Here's my current disclosure list. I think this may be past 3 years. One important way of managing the possibility of conflicts of interest is just full disclosure of therapeutic, of your relationships. I do consulting to the pharmaceutical industry because I think they represent our best hope for the development of new treatments for our patients. But it's also true who you spend time with, how you earn money, influences what you think and how you think about. And with that in mind, normally I also disclose my wife, who works for a company that does business with several pharmaceutical companies. And I think she's in the audience tonight, but she's off today's disclosure list, ironically, not by my choice. So there are some drugs that are being talked about today that are not yet FDA approved. And there's a short list of those drugs here. This is not about promotion. This is about understanding mechanisms that promote and sustain depression and potential remedies that are under development. So as you know, major depressive disorder and bipolar disorder together constitute the world's second greatest public health problem. And this is relatively more so in the industrially developed countries, but it's true worldwide. In the United States alone, it's the leading cause of workplace disability, and bipolar disorder, even though it's only afflicting about 3% of the population, is the 8th leading cause of disability. Of course, if you have a mood disorder, it makes every other problem you have in your life worse, and this includes health problems. And then finally, it is the principal cause of suicide, which across all age groups is one of the 12 leading causes of death in the United States, and one cause of death that's actually been on the rise in the past few years. Now, for the past 20 years or so, we have had relatively safe, relatively easy to use first-line antidepressants that promoted the ability to treat depression in primary care like it had never been possible before. But we've reached a plateau in terms of what we're able to do with these generations of treatment. And we've got some real unmet needs staring us in the face. And the first is that although these medications work, they work in relatively modest, specific ways. And the nonspecific components of treatment are more important than the actual specific action of the drugs. So this means that when patients don't respond to your first or second choice of treatments, you've pretty much used up your aliquot of non-specific ingredients, and now you're down to specific efficacy. You've done what you can to restore the person's morale and engage them in the process and do problem solving and so forth. So now you've got to really bring to bear more specific agents. And if you don't have different specific agents that work through different mechanisms, the chances of getting people better after, say, 6 months of treatment plummet down to about 10% per try. Of course, the SSRIs and the SNRIs are reasonably well tolerated, but maybe 1 in 10 of us can't stand one or another of their side effects. They're not especially good treatments for some really troubling symptoms of depression, including insomnia and some forms of anxiety. And because these medications modulate gene action, and that process takes several weeks or even a month to develop, they're slow. And people do indeed sort of begin to respond, but people don't cross the line from ill to better or from better to well until they've had 4 or 6 or even 8 weeks of treatment. And as I said, if you've not responded to a really good couple of trials of monoamine modulating antidepressants, your chances of success with a 3rd or a 4th trial that works through that similar mechanism plummets down to relatively little. So here are the monoamine mechanisms of interest, and this is a slide. I did a little topography through the history. This comes from a very prestigious book that was published in 2003, and this pretty much lays out where the targets of our 1st and 2nd generation antidepressants were, and those are the ascending tracks for serotonin and norepinephrine, that basically from the brainstem up, often in close company, norepinephrine and serotonin had important modulating effects for appetitive drives, for either enhancing or dampening stress response, for the ability to calm, to fall asleep, or the ability to stay alert and aroused. And there was good evidence that medications that modulated these medicines, starting with that modulated these neurotransmitter systems, starting with the tricyclics and the monoamine oxidase inhibitors, could treat a significant portion, maybe 2/3, of the people seeking treatment for depression in that era. But of course, even by 2000, we knew it wasn't just about serotonin and norepinephrine, and that depression wasn't a disorder of serotonin or norepinephrine abnormality. And so you began to look at kind of these hierarchical models in which you looked at the fundamental neuromodulators, norepinephrine, serotonin, sometimes dopamine, but then you began to look at components of stress response, such as CRH, GABA as a modulator of stress response. We began to learn about the role of inflammation. Chuck Raison gave a wonderful talk immediately before me. I will not go into great detail about that here, because you just heard 75 minutes of the best. But then coming to understanding, say 10 years ago or a little more, the notion that there were resilience systems in the brain that could both counteract the effects of stress on neurons, but also be damaged by sustained stressful environments. And of course, the impact of BDNF was the best understood here. And so now it wasn't just norepinephrine, serotonin, and sometimes dopamine, but you had all of these secondary potential effects for seeking better treatments for depression. And unfortunately, efforts to work through CRF, efforts to work through GABA until very recently have not led to any new therapeutics, and no targeted intervention directly at BDNF has led to new therapeutics. So if you think of the neuronal tracts as the wiring innervates the structures that take part in the systems, and the relationship between the systems, the circuits. And so prefrontal cortex, anterior cingulate, amygdala, and hippocampus represent 3 really important structural areas for which these circuits modulate. And we don't yet have a good map of the full circuitry of the human brain, but you can do more kind of invasive things with rodents. And there are at least 6 or 8 of these circuits in rodents that are really important in modulating well-being, which you can disrupt or distort in various kinds of paradigms that involve horrific, sustained stress. So for example, the little rodent living in a cage next to the predatory, hungry cat with only a thin, flimsy wire separating the two of them. Imagine living day after day after day in that kind of circumstance. The rodent at least has the knowledge that that cat is a hungry predator, right? But can't do anything about it. This begins to damage the activity of these circuits. And we understand now some ways to minimize that damage. Of course, getting the rodent out of that circumstance would be the best way to minimize the circumstance. So here you see, now we're going from circuitry to actually looking at the activity of neurons. And so here we're measuring blood flow, and the blood flow follows the neuronal activity. And in this particular slide, areas of increased activity have brighter colors to draw your eyes to it. But in classic severe depression at midlife in people with a family history of depression, so this is melancholia at its purest, you can see 3 of these regions of the brain showing increased neuronal activity. So the work of depression in terms of the brain in classic severe depression involves increased activation of the amygdala, the ventrolateral, and medial orbital areas of the prefrontal cortex. So if we are looking for a circuit-acting treatment, you want something that can dampen down the activity or promote restraint. So either dampen down or promote restraint. So we'll come back to this topic. Now, if you'll remember, in the 70s and 80s, there was quite a bit of interest in hypercortisolism as one of the potential mediators of classic severe depression. Interestingly, the profile that I just showed you is quite strongly related to being hypercortisolemic. So there's old biology kind of reinforcing newer biology. So this state of uncomfortable central activation, dysphoric activation, is associated with hypercortisolemia. And in turn, it is associated with these more systemic responses that sustained severe depression can engender. Some of the things that Chuck Raison talked about. So your blood pressure going up, your insulin metabolism being altered, changes in your pain perception, and then of course the changes in the depth of your sleep and the quality of your sleep that go along with it. And if this sustained activation is continued over weeks or months, the brain begins to show evidence of reduction in volume. Maybe not cell death, but reduction in the richness or the wealth of the cell's environments in several key regions. And one is the subgenuum of the anterior cingulate. So this key way station for anticipation, planning, pursuit of life's pleasures starts to go down. And unfortunately, the hippocampus, another key way station, in part for the retrieval of memories, but in part also for actually dampening down or modulating the glucocorticoid part of the stress response. And so this is a primary reason that we want to treat depression before it becomes severe. We want to prevent 3rd and 4th and 5th episodes of depression because these changes, these kinds of damage are cumulative, and the older you get, the more easily damaged your brain may become because of this. And what Shalene found in St. Louis was that the size of the hippocampus was directly related to the number of lifetime days of untreated depression. And when she counted the number of lifetime days of treated depression, there was no association with hippocampal volume whatsoever. So the impact of this damage to the hippocampus really is directly related to the weight of the burden of depression that you suffered in your lifetime. And just to pile on a little bit, and this is a small study, it's not been replicated to my knowledge, but the size of the damage to the anterior cingulate also appears to be related to the quality of antidepressant response you're likely to obtain in the inverse way. So more damage, less dramatic benefit from standard antidepressants. So at this point, I'm talking about possible systems involving neurotransmitters, possible processes, things involving like resilience, neurogenesis, synaptosomogenesis, and so forth, and then the end organ phenomenon that we call depression. And I've said we've got platforms of moderately good treatments that are reasonably safe, and that some of these new developments will be tested as additives to these platforms. But indeed, it may be possible that eventually some of these new developments may be useful treatments as standalones on their own. So in my remaining minutes, I'm going to talk about developments involving glutamate, GABA, endogenous opioids, and inflammatory cytokines. I'll make a few kind of extemporaneous comments about things that I've been keeping track of with some classic hallucinogens also. So this is a unique neuron here because it's containing receptors and transporters for serotonin, norepinephrine, glutamate, and CRF. And I don't think such a neuron actually really exists, but some neurons do have receptors for more than one neurochemical. And so in addition to the classic monoamines, serotonin and norepinephrine, what we're trying to do with this schematic is show how modulating glutamate or modulating CRF might have additive or enhancing effects on what standard antidepressants might do. And so I think importantly that for glutamate, you also have the role of the glial cells. And so here you have these supportive cells that used to be thought of just to be involved with making the connective tissue that the neurons set in. But actually, these are the cells that involve sucking up glutamate after the neuron fires. And glutamate, of course, is the principal excitatory amino acid. So here's a fifth potential player here, a husband cell, if you will, one that sits out between the neurons in the glial space and basically supports the well-being of the cells. But if you notice, each of these receptors or transporters has pathways that go to cell nuclei, and they all end up kind of interacting at the level of gene expression involving resilience. And so this is suggesting that we have multiple pathways to get to where we want to go, and that in particular, some of these other newer systems may get to those pathways in a way that is much faster than our current one. So I do think the NMDA receptor, which is one of the two principal receptors for glutamatergic neurotransmission, is the target receptor of the second decade of the 21st century. And this is a complex receptor. There are multiple sites, one of which the central pore, the ion pore site, is the target of ketamine. And you all know the ketamine story. I will come back to it in a moment. But this is a rich receptor with multiple other targets. And the fact that ketamine was discovered accidentally, the antidepressant effects of ketamine were discovered. It's no different than the antidepressant effects of imipramine or the antipsychotic effects of chlorpromazine, that you have drugs with multiple effects for which one desired effect has an antidepressant outcome, but we have the baggage associated with that original drug. But this particular receptor gives the possibility of multiple other actions. Now, this is from an animal model. It's some of these really seriously stressed rodents. These were stressed further by being beheaded, I think. And the animals were placed in some horrific situation. They developed something like learned helplessness or a social defeat response or just basically a beatdown. And half of the time they got this along with saline, half of the time they were given ketamine infusions periodically along the way, and a single ketamine infusion could begin to counteract or reverse the the negative neuronal effects of sustained chronic stress. And so these animals were not doing ketamine for recreational purposes. They were not getting high. They were not looking for dissociative effects. The drug was being given to them without consent, but it had the effects of counteracting or minimizing the negative effects of the stressful circumstances they were in. So I will just tell it the way I think it is today, and that is that I think that ketamine has been the greatest thing for TRD since electroconvulsive therapy. And I think this because we were at an impasse in therapeutic development before these investigators in New Haven noticed that some of their depressed controls had pretty dramatic mood effects. This is 20 years ago now that this was first observed. And this old generically available dissociative anesthetic was really subsequently shown to have significant, rapid, and unique antidepressant effects. Now, to just tell the full truth, this drug is related to PCP. It's not as noxious as PCP, but if you use it the way cocaine addicts use cocaine, namely that you get the high, you dose to the effects of the high, and then you chase the high every 2 to 4 hours with repeated dosing, you can get into all sorts of trouble with ketamine, including the development of cognitive impairment and some evidence of CNS toxicity. So this is a controlled substance for a real reason, and there are parts of the world in which ketamine abuse has been profound, much more worrisome and difficult than it has been in the United States. Now, we have had the first evidence from properly controlled studies that ketamine had rapid antidepressant effects for about 12 years now, and we now can say with pretty good certainty that if you take about 1/4 of the anesthetic dose or about 1/2 of the desired intoxicating rave drug dose of ketamine intravenously, that you have about between a 40 and 60% chance of having a fairly dramatic antidepressant response evolve over the next 24 hours. Now, the dissociative effects, and if you have a hallucinogenic or a trippy kind of effect from it, typically dissipate within 40 to 60 minutes. And the correlation between those intoxicating effects and the therapeutic benefit is on the order of 0.2. It is trivial. It is not significant. People can have powerful antidepressant effects without any trippy experience whatsoever. People can have the maximum trippy experience. They can see flowers emerge from the walls warble, and so forth, and have no antidepressant effect. When you benefit from this drug, typically your antidepressant effect is sustained for somewhere between 3 to 7, sometimes even 9 days. The half-life has fully cleared. You are seeing a sustained antidepressant effect that lasts for 7, 10, 12, 15, 20 times the half-life of the drug. This is not related to the abuse-worthy potential of this medication. The efficacy studies done to date have largely been limited to 1 or 2 weeks. There are a handful of studies now that go out to 3 to 4 weeks. There will soon be studies going out to 12 weeks. If you play state-of-the-evidence games, if you look from the ketamine clinics in the United States, there are anecdotal reports of patients being successfully sustained in remission with once-a-week infusions over the course of several years. This is level 3 evidence. It is not controlled, and it is not sufficient to reassure us that there is no danger signal here with long-term treatment. But we are a lot further along today than we were 10 or 12 years ago in this evidence. This is the meta-analysis commissioned by the American Psychiatric Association. It was published a couple years ago in the Green Journal. The upper slide is the one-day effect. The lower slide is the one-week effect. These are forest plots. The therapeutic activity of ketamine at one day has an odds ratio of 10. There is no other treatment that does this. At 1 week, there is an odds ratio of about 6. No other treatment, not even ECT, does this. These are dramatic and meaningful effects. It doesn't work for everybody. The more complicated and treatment resistant the patient group is, the lower the probability of response. But even in those patient groups, you see 35–40% of patients have significant effects. So that's the positive part of the state of the art. We still haven't answered the question of tolerance to the satisfaction of the FDA. So whatever the first drug is that comes forward will carry with it a very stiff post-marketing commitment to follow people carefully, ensure they're not developing loss of effect or progressively ascending dose. Likewise, there will need to be studies of neuropsych performance, perhaps even serial MRIs, to ensure that once weekly treatment over the course of a year or two is not associated with neurotoxicity. I am an optimist by nature, and I hope that what we saw in those rodents with restoration of cellular resilience might translate to humans in the sense of people beginning to be able to respond to more conventional antidepressants again after a period of well-being with ketamine therapy. This remains a hypothesis, not a fact. Another hypothesis is that rich complexity of the NMDA receptor may well point to targets that aren't associated with neurotoxicity or intoxicating effects and so forth. And we'll hear a little more about that in a moment. So here are the three leading contenders to get to the market one may get here before the third decade starts. The other two still may get here early in the third decade. The first is Esketamine, and so as you know from S-citalopram, Esketamine is the S or the SINIST or the left deflecting stereoisomer of ketamine. R-ketamine is a perfectly good stereoisomer. Also, it is simply not under this kind of level of development at this moment in time. The wrinkle on esketamine is that it's being developed for intranasal delivery, whereas ketamine principally has been studied with intravenous delivery. Someone told the manufacturer that psychiatrists were not good at starting IVs. It's a rumor I've heard. I just thought it was me. But the intranasal delivery will make in-office much more accessible for patients than the requirement of going to an infusion center or a special ketamine center. Phase 3 has now reached completion since I wrote the slide. The application will be reviewed shortly by the FDA. It's conceivable we will know by the end of the first quarter of 2019 if this will be the first FDA-approved glutamatergic treatment. Now, I mentioned that the complexity of the NMDA receptor gave the opportunity to actually make designer drugs, and indeed the first designer NMDA antagonist is a drug that used to be called Glix-13. It is now called Rapastinel. And it is an allostatic modulator of the NMDA receptor that was basically synthesized from a impression of the receptor. And so this drug, because it was only going after one element of the NMDA receptor, lacks ketamine's intoxicating properties, does not affect blood pressure, does not have dissociative properties, and could not be used in any way, shape, or form as an anesthetic. So it is a completely different drug than ketamine. The proper abuse liability studies have not been done yet, but since none of the humans who have depression who have gotten this have had any salutary or euphorogenic experiences with it, I assume it will have no value as an intoxicating drug. Rapastinel, I'll show you some slides on it in a moment. It is in phase 3 for pharmaceutical studies right now with both major depressive disorder and acute treatment of suicidal crises in people with major depressive disorder as targets. And then Lanicemine, which was originally developed by AstraZeneca, but now being developed by a different company is a potentially orally administrable medication that has less acute effects at the site, at the target site of the NMDA receptor, and as a result, it was developed to have much less psychotoxicity than ketamine. So a second wave of studies is in the planning phase for Lanicemine. I'll show you the trial. So Esketamine, stereoisomer of ketamine. Every patient who's gotten ketamine has received basically 0.2 milligrams per kilogram, at least, of Esketamine. So guess what? It works. It works exactly like ketamine, although with intranasal delivery, you don't get quite as rich a psychoactive experience in that first hour, and possibly drug exposures are maybe 80–90% of what you might get with intravenous exposure. It looks like the best dose for the average patient's 54 milligrams. We are not all average people. Some of us will do quite nicely on lower doses. There may occasionally be a person who does better on a higher dose. This is one of the studies that will be considered pivotal if the FDA approves. And this, I think people are shocked that the placebo does so well in this study, but this is what happens when you go from a kind of a craft beer model in which one investigator, like at the NIMH, tightly controls the situation and does it very careful, and then you go out and do a study at 30 sites or whatever. Invariably, the placebo response goes up, and particularly with all the tub thumping that's been going on for ketamine and the enthusiastic articles about it and so forth. So, but nevertheless, that difference between drug and placebo in a design in which patients were also receiving a brand new antidepressant represents a number needed to treat of about 5, and that is a perfectly good therapeutic effect for patients who have been desperately ill and not responded to multiple antidepressant treatment trials. Now, there is no free lunch. Even at the U.S. Psychiatric Congress, you have to hear a lecture to get a free lunch, right? So when you take intranasal esketamine, there's about a 1 in 4, 1 in 5 chance you'll have something on the milder order of a trippy experience, a little dissociative sense, some illusions or something like that. There's an occasion that you might vomit. You will sometimes, 1 in 4 chance of feeling dizzy or unsteady on your feet. You might even get tingling. And about 1 in 10 patients will have a tangible and uncomfortable increase in their anxiety associated with this experience. You can look at the drug-placebo differences for tolerability, and these studies aren't fully blinded because the drug reveals itself to people in lots of different ways. But this, if you go back and you look at the tricyclic era studies, amitriptyline functionally unblinded itself a lot, as in the second generation antipsychotic studies, so has quetiapine. So I think it'll be important to show that the therapeutic benefit isn't directly tied to the experience of recognizable side effects. So that is kind of where I'm going to end up with the esketamine. The phase 3 package is complete. There are 3 positive studies. It's under the FDA review. You should hear before April about that. Rapastinel is about 1 year into phase 3, so a couple years behind. This is the drug I mentioned that was the designer synthesized drug to target an aspect of the NMDA receptor that was not involved with the psychoactive kind of the potentially abuse-worthy psychoactive effects of ketamine. These are the animal studies, which I think importantly had ketamine as an active comparison. And in every one of the animal tests of relevance, this compound, Rapastinel, performed similar to ketamine. So in terms of animal models, even though it wasn't associated with, say, blood pressure effects and so forth, it had the antidepressant effects that were comparable to ketamine. This is the positive phase 2 study, and that green bar at the top, I guess it's, is it some shade of blue or green at the top, and the green bar at the bottom, the 30 milligram dose, are exactly equivalent. So placebo and the largest dose of Rapastinel were equally useless in this study. You can see that people got better, but they were not nearly as better as the patients who received 5 or 10 milligrams of Rapastinel by infusion in this study. So the effect was recognizable within 1 day and was sustained across 1 full week after a single infusion for the 10 milligram dose. This is the second phase, or this is the phase 2B study in which patients were randomized to receive either frequent or infrequent doses of 5 milligrams or 10 milligrams. And now remember, the heavier dose didn't work in the first study. Here, getting the drug 4 to 5 times a week did not work nearly as well as getting the drug twice a week. And so infrequent dosing appeared to be more effective than more frequent dosing, again suggesting, as was the case with ketamine, that infrequent dosing, in ketamine's case once or twice a week, has greater therapeutic effects. So these are not the antidepressants that we learned how to prescribe. They behave considerably different. Now, we've all learned how to prescribe GABA-ergic medications called benzodiazepines, and we know they have some modest antidepressant effects, but probably more palliative. And you know that benzodiazepines are related to chronicity of depression. When you look pharmacoepidemiologically, the more likely a person is to use a benzo along with an antidepressant, the more likely they are to be on a chronic therapy. And so there were some benzos that were briefly looked at as possible antidepressants, alprazolam in the 80s, adinazolam in the late 80s, early 90s. Ultimately, it was decided that the intoxicating effects of these drugs, their potential for misuse and abuse, were just too high, and they kind of knocked in the backwash of the SSRI and second-generation antidepressant era. Now, if you move this into the modern era, we also have new concerns about benzodiazepines and aging. And of course, you know that benzodiazepines increase your risk of falling, of hip fractures, and more recently, an association between chronic benzo use and a greater risk of dementia. That's a scary one. So there are reasons that we have not gone full-heartedly after conventional GABA-ergic kinds of strategies. But there's another way to relate to GABA receptors, and that's through, we learn this through a neurosteroid called allopregnanolone. And this actually is not an actual binder of the site, but an allosteric modulator. And so that means it can exert some of the benzodiazepine effects, calming, for example, without inducing sedation or the intoxicating effects. And so this new model of interacting with the GABA-A receptor, this allosteric modulation, has become interesting because of a different therapeutic observation for allopregnanolone, and that was, this drug was initially developed for treatment of epilepsy, and then as a targeted treatment for severe, overwhelming postpartum depression. And the reason it was targeted for that particular indication, of course, is that the massive drops in progesterone that occur with childbirth have been thought for eons to be linked to these severe, potentially life-threatening postpartum depressions. And there was a compound, allopregnanolone, that if given intravenously could kind of counteract that effect. And so this drug was studied just a few years ago now in a very careful but small study of postpartum depression, only 22 patients here, intravenous infusion, but a single dose, slow dripped in over, 36 hours, resulted in a 70% remission rate in a patient group that was basically not responsive to placebo. The placebo, it's a single 20%, 2 patients got better on the placebo in this small study. So I remember from the 70s and 80s occasionally seeing MOAs or adding an antipsychotic for psychotic depression have an effect like this, but we've not seen massive kind of effects like this from a non-intoxicating drug in recent times. So this compound is now known as Sage 547, brexanolone. And in addition to the study I just showed you, there is now a large-scale, properly done, placebo-controlled replication study in postpartum depression in which it worked nearly as well in the second study. And there has been a kind of test study done in men with depression in which it worked as well. So this brings us back to the neurosteroid story, because we are now not talking about treating progesterone withdrawal. We're talking about a compound that can rapidly engage the GABA system to kind of counteract this central stress response in a way that doesn't have the baggage of our conventional GABA agonists. So behind 547 is another compound called Sage 217, which is a related compound, but its pharmacokinetics permit it to be orally delivered. So the major drawback of a 36-hour slow infusion is that, who's going to really agree to that? And who will give it? Who has a 36-hour infusion center outside of a hospital setting? But if you can deliver anything similar to this through oral delivery, then we have another interesting, serendipitously discovered antidepressant effect for people. Now, here's one that wasn't serendipitously discovered, and that is addressing the endogenous opiate system. This was not serendipitous. Well, I guess the original discovery that you could smoke poppies was a serendipitous discovery, but human beings have used the opium cure for centuries. And the opium cure, of course, has transient benefits, but not sustained benefits. And now, at any time in kind of modern life, we're coming to terms with recognizing what liberal, broad-scale prescription of opiates, what kind of problems can go along with this. Nevertheless, it's recognized that the opiate system has an important role in regulating well-being and in calming in the face of dysphoric stress. And how many of you have prescribed buprenorphine in a pinch to a difficult-to-treat outpatient? 10. How many of you have prescribed tramadol in a pinch to a difficult-to-treat? Right. So some of us have been there and done that, and we do know that occasionally you will see people who have depressive syndromes that are responsive to opiates who don't run into trouble with habituation or tolerance with the dosing. So when we talk about the opiate system, we can target the mu, the delta, or the kappa, and the mu is more closely related to reward. The delta system is the one that has been most implicated with potential antidepressant effects in animal studies, and the kappa, interestingly, has, if stimulated, has kind of has aversive effects, so pro-depressive effects in animal studies. And animals, unlike humans, give these opportunities for experiments because you can now breed rodents who have knockouts for each of these receptors and engage them in various kinds of experiments to look at what total knocking out the receptor activity can do. So when we get back to humans, we now know that the placebo effect is largely explained through activation of the endogenous opiate system. So the ability to feel good through suggestion and expectation is mediated by our internal opiate system. And the nocebo effect likewise is explained by the failure to engage the opiate system. So when suggestion, violation of expectation results in you feeling bad, angry, pain, whatever, that's through the failure of the opiate system to engage. I mentioned bupropion. About 10 of us admitted to having prescribed it on occasion. This is a controlled substance. It is approved for management of pain and has some secondary role in treatment of opiate dependence. It is also an ingredient of Suboxone, so in combination used for treatment of opiate dependence. So it is a kappa antagonist as well as a mu partial agonist. So it has mixed activity, but it is better at kappa antagonism than it is at mu agonism, and it has a high associated with it. And if you get a high with it, you can increase the dose and get an even better high with it. There is one single study with relatively low doses of buprenorphine, not even a milligram a day, about a half a milligram a day on average, with a placebo control in depressed people with suicidal ideation, and the treatment had a significant beneficial effect on subjective dysphoria and suicidal ideation, and the abrupt discontinuation of buprenorphine after 4 weeks of treatment was not associated with a withdrawal state. ALKS 5461, buprenorphine, is combined with samidorphan. And here, samidorphan is a very, very potent mu receptor antagonist. And it is samidorphan that blocks, basically ablates, the ability to become high or to become euphoric, to want to take buprenorphine. So this is modulating the ability of the opiate to relieve dysphoria without having an intoxicating effect. This has been studied at various doses, and the 2 milligram dose is the one that has been developed for ALKS 5461. It tests positive in some, but not all, animal models of antidepressant effects. It has been given to experienced consumers of opiates, people who like to take opiates for recreational purposes, and they give it very poor marks for its intoxicating abilities. It is not liked at about the level of a placebo. So there are 2 unequivocally positive studies with ALKS 5461. Both have used this sequential parallel group design in which patients are first randomized to placebo, active drug, and if you don't respond to placebo, there's a second randomization in which you may receive active drug in the second portion of the study. As you can see, there was no advantage for the higher dose in this first study. Things tended to lean even for the lower dose, and since the lower dose is better tolerated, that's why the 2 milligram dose has been pursued. Here is the second study, the second unequivocally positive study, and in that study, the drug-placebo difference was not evident until the second phase of the trial. There are several other studies that failed to show significance. The whole package is before the FDA. You may learn about it before Christmas time, whether you might be able to prescribe this next year for your difficult-to-treat patients or not. Since buprenorphine is a Schedule III narcotic, there's every reason in the world to believe this will be a Schedule III drug. Nevertheless, there are safety data out to a year, abrupt discontinuation data. It certainly does not. You pick the wrong time to bring an opiate target drug to the market, right? But there does not appear to be any complicating, intoxicating, or abusable qualities with this. I should mention, if you hang out with opiate devotees, that this is an integrated, melt-in-your-mouth wafer delivery kind of treatment, and chemists cannot cook it and make it into something that you can snort or shoot that separates the 2 elements of the ingredient. You would be much better off, it's much cheaper just to buy buprenorphine on the black market if you wanted to do that. So how many of you were here for Chuck Raison's talk before me? So I didn't know he would be immediately before me, so this was in my talk. I apologize for not doing as good a job in 8 minutes as he did in 90. You've got inflammation being an important part of the pathophysiology of depression. This has been known for more than a decade now, and it is likely to be a diffuse response that goes along with the modern human condition, because there's a strong tie to being overweight or obese that goes along with it. And we know that immune markers such as CRP or the ILs and tumor necrosis factor alpha are all associated with greater risk of depression or poorer response to SSRIs. And so if we just look at what's present in depressed people, this is a meta-analysis of studies. You can see there are thousands of patients here, and not everybody has all three, and in fact, maybe only a third, 40% of us, when we are depressed, have one of these super pro-inflammatory kinds of responses, but it really is here, and this really is part of the pathophysiology of depression in the modern world. Should our depressed patients all be on anti-inflammatory agents? No. If you don't have the inflammatory profile, being on an anti-inflammatory doesn't help, and sometimes it actually appears to make matters worse. And so this is one of the famous studies that Chuck led. And if you just go to the right and you look, the patients who had low levels of CRP actually did better on placebo than they did on the anti-inflammatory medication. But if you are stuck and you are grasping at straws for what therapeutic strategies to use, I would think about getting a CRP as an inexpensive marker of inflammation, and then think about doing a trial. And as Chuck mentioned, the omega fatty acids may well work through the same mechanism. This is the meta-analysis of all the anti-inflammatory studies that had been done as of a couple years ago, and you can see at the end of the day that there's about a 5 to 10% advantage over placebo for all of the anti-inflammatory drugs rolled together in this meta-analysis. So there is a modest amount of truth here. I think a lot of work is yet to be done to find the right anti-inflammatory drug for the right patient under the right circumstance. I mentioned Lanicimine. Here are some of the other drugs that are being marketed that I will just make a mention of, and then I do want to talk a little bit just off the cuff about a couple recent studies that have been done with psilocybin. But one very interesting compound is called AXS-05, and this is pairing bupropion, good old Wellbutrin, with dextromethorphan, the active ingredient of Robitussin DM. And what happens is the bupropion is a 2D6 inhibitor, and when you have a good level of 2D6 inhibition, you can't metabolize dextromethorphan, and it accumulates, and it begins to have NMDA antagonist kind of properties. And so in animal studies, this interaction between bupropion and dextromethorphan had enhancing antidepressant effects compared to bupropion by itself. So this is being studied as a combination therapy. Interesting argument that you might be able to get an enhancing effect from an ancient cough syrup ingredient. Circ 301 is another targeted glutamatergic strategy, this focusing on the NR2B specific site of the NMDA receptor. This drug failed in its most recent study. I don't think it's being investigated at this moment. Another drug on the horizon, two drugs on the horizon. One is a mixed serotonin and dopamine reuptake inhibitor, along with some postsynaptic serotonin effects, and then there are the oxytocin kinds of compounds that are being studied. And then finally, compounds promoting neurogenesis are being studied as well. None of these are in phase 3. None of these will be in your hands within the next couple years. Lanicimine, as I mentioned, is coming back into phase 3 in the near future. So that's my version of kind of what's changed in the understanding of the neurobiology of depression over the past 20 years or so, and some of the therapeutic developments that are practically right around the corner for possibly helping our patients who don't respond to conventional therapies. We really did come a long way between 1960 and 1990 or so with the development of safer and easier to use basic antidepressants, and monoamine modulation through these safe and easy medications really do provide a good answer for 50–60% of our easier to treat outpatients. But of course we got to the end of the line with those medications, and there probably can't be better serotonin reuptake inhibitors or better serotonin norepinephrine reuptake inhibitors than the ones that we already have. So the recognition of especially glutamate in the acute activating stress response, and then the accidental discovery that a glutamatergic the NMDA antagonist, ketamine, could have such rapid and unique antidepressant effects has set in motion kind of a revitalization in the study of the psychopharmacology of depression, and may well lead to safer and easier to use drugs down the line. Likewise, although I was playful in saying you couldn't think of a worse time to bring an opiate modulator into the market, it is also true that human beings have known that there is something useful and calming about what activating the internal endogenous opiate system can do. And the ability now to tailor drugs that modulate in a combined way may be able to capitalize on this therapeutic effect without the worrisome and dangerous qualities of these medications. And then finally, I think the discovery of neuromodulation, of neurosteroid modulation of the GABA system, the GABA-A receptor in particular, has reopened the possibility of the calming effects of benzodiazepines in combination or by itself for patients with more difficult to treat depression without the kind of worrisome side effects of those medications. So I want to thank you for your kind attention.
A question for you.
Sure.
With ketamine and Esketamine, a lot of it's a glutamate activity, right? But also, to get back to the psychedelics, the dissociative aspects of it, might that be helpful? And kind of aside, have trials been done? No one wants to do the dissociative stuff because that won't look good.
So there's there's a brave company in the UK that, and I meant to make a comment about this and just passed right over it. There's a company in the UK that actually has gotten the license to study psilocybin, magic mushrooms, and they did their first study in people who were dying of cancer, who had terrible pain and depression, and they had terminal cancer, and the drug had a remarkable antidepressant effect. Yeah. And so you basically provide a guided trip experience with a counselor who does basically kind of is a positive spiritual guide through the experience, and in that population it worked. So they did another study in less horribly ill cancer patients with the same scenario, and it worked in the second study too. So now they are beginning to mount a study of treatment-resistant depression, and they've signed on 6 or 8 U.S. sites. But
they're going to go with higher doses of ketamine then for these?
Psilocybin.
I know psilocybin is being used, but I'm just curious about ketamine. If higher doses, if it might have some of the same benefits.
So I think there were so many stigma and legitimate concerns that the higher dose studies can only be done when it's proven and in regular practice. Okay. And then I think you can do the higher dose studies.
And one other quick question: with the glutamate interactions, what about cannabinoids? Are they starting looking into some different cannabinoids with glutamate downregulation?
There's fair evidence, if I play the evidence-based medicine game, there's fair evidence that cannabinoids have anti-anxiety effects. Mm-hmm. There's little evidence that they have antidepressant effects.
Thanks.
Yes, this is kind of abstract. I remember years ago at a lecture hearing about a particular patient when they were doing deep brain stimulation for Parkinsonism. Yeah. that they hit a one little spot where she got the right amount of juice and became profoundly depressed immediately with a full panoply of symptoms and suicidal and whatever, which just makes you think about depression. Nobody thinks it's a little spot in your brain. Yeah. But the broad experience of a depression with all the various symptoms that are expressed made me wonder about, or makes me wonder about, is it some circuitry kind of thing that has to sort of all go together and you interrupt a circuit?
Yeah, so that's why TMS works, that you really are targeting one region in these circuits at a level that you could just get enough magnetic energy there to alter the circuit's activity. Now, unfortunately, that circuit's not relevant to more than half the people who have depression, and you can't always get enough energy there even when it is relevant. But we've tried deep brain stimulation in the US twice, and neither study succeeded. Helen Mayberg can occasionally find a patient who gets a transformative response, but we can't replicate it yet in a multi-centered way. But no one's truly given up on that. It's just there's a moratorium for the moment because the chances of doing good aren't being offset by the potential for harm. But I'm sorry to interrupt.
No. The broader question was more our previous conceptualization that it was monoamine and the three biggies that all contributed to how a depression feels and how it generates symptoms has to be modified now with the NMDA receptor and some of the other things to just sort of have an overview theory of depression and what it really is. So that was sort of my question of if you've got insight into that general notion.
So my own belief is that we evolved and that depression is an elaboration of our defeat, the way we feel when we're defeated or the way we feel when we're bereaved. And this is why love and work are so important to us, and this is why exit events and professional setbacks are so important, and that there are little genetic factors, not big genes, but little genetic factors that make some of us more impervious or more resilient, and others more vulnerable. Having horrible things that happen to us early in life sets in motion epigenetic changes that alter our risk profile, as well as alter our ability to fully enjoy and benefit and capitalize on life's rich banquet. And so these are really complicated, fundamental human conditions. And even though we can defeat rodents and chronically stress them, they're not exactly experiencing the same thing that people are, because they didn't participate in the circumstances that got themselves in that cage and don't have long past histories and can't remember generations of stories about their families and the things that make the richness of our depressed patient's life. And this is why touching a single spot might only help 1 in 100 patients and not enough to use that treatment. So, yes?
I was curious when you were going over the new therapies that at least the side effects you listed didn't seem to include mania. So one of the things that we have even less treatments for is unipolar depression, is bipolar depression. Is there any work being done on that? Have we given ketamine or some of these other therapies to bipolar patients, and what do we know about that? At
the NIMH, the original study that was done with unipolar depression had a slightly smaller companion study done with bipolar depression, and they did require that the patients be on a mood stabilizer for that study. And the antidepressant response in bipolar depression was about 80% the magnitude of the antidepressant. So the bipolar patients were slightly less benefited than the unipolar patients. And they may have been more treatment resistant, however. And so we don't know if it was the lithium or if they were more treatment resistant. So some of these developments will be equally valuable for our patients with bipolar depression.
Thank you.
Hi, could you comment on the feedback loop in the opioid system in the brain whereby kappa receptors turn off the reward instilling capability of the opioid system and induce a dysphoric kind of frozen state in its place?
No, I have the same clinician's level understanding of that loop as you do. I simply, when I talk about the receptors, kappa's the one that has the dysphorogenic effect, and it's through this feedback loop, but I don't know what intracellular mechanisms explain that.
Okay, thank you.
Anybody else miss any? Okay, enjoy the rest of the conference. It's good to see you all.